Hey everyone, I'm just going to put the attendance slide up for us. Sorry it took a minute. I just had to pull it up. It was taking a while on my computer, but we'll wait about 5 more minutes and then get started with the meeting. Okay, I think we're good to get started. If you haven't scanned the attendance link, just make sure you use your NC State email to log in for that. And we'll just go ahead and get started. Our last pre-med meeting of the semester. So thanks to everyone who came to all our meetings so far. I hope you guys have enjoyed them and enjoy this one. All right, just a couple reminders for the mentoring opportunity that I sent out last week. Someone will be in touch with whoever signed up for that shortly. So just keep an eye out for that email. It won't be from me, it'll be from someone at ECU that will send that email out to you. Also, peer health advising, if you guys are interested in that with Dr. Easterlin or Gabrielle, who's the other pre-health mentor, you guys can click on this link that I'll send out in the recap email. One more thing is the MCAT study group we had planned for this upcoming winter and next spring. If you're interested in that, please let me know, and we can figure out times, when to study, things like that. And just keep an eye out for the recap email because that's also going to have a lot of information going forward. And with that, we have our speaker today, Dr. Julie Casani, who's the Director of Student Health here at State. Dr. Casani, if you just want to introduce yourself, go for it.
Yeah, I think many of you know me because you've either gotten tested and got lab results from me, or sadly, you may have even gotten a T or positive note from me. I hope not. So yes, so I'm Julie Casani. I'm the Director of Student Health. Been here for about 4 years, and I probably will tell you a little bit more about myself as we move through this. So it's great to be here, and 2 more weeks, guys. 2 more weeks. We can do it. We can get through this semester. Good job. I do not have a presentation. Pavitra asked me if I had a presentation. I don't. What I thought I would do is just sort of chat a little bit and then mostly take questions. So if that's a good format, that's good with me. Is that good
Yeah,
for you
that's
guys?
perfect.
You
I
can
was
tell
just
we're
gonna-
very well choreographed here this afternoon.
No, that's okay. I was just going to start off by asking, about your undergrad, and why you chose to get into public health.
Yeah, the great questions. So I actually, in celebration of this week, I'm actually a first-gen student. So my undergraduate was at NYU. When I was going through, it was traditionally everybody straight track. Nobody took time off because that's not the way things were done. But so I straight tracked through, majored in biology, minored in French actually, and wound up going to NYU Medical School close by in New York. So that was my undergraduate and so on. I had done some work. I was actually an EMT on a volunteer ambulance in New York City. And that was, again, during a time when that wasn't such a traditional way of getting experience or any of those things. There really was no formula at the time for getting into medical school, or at least no apparent formula. I was just very interested in, I guess that kind of foretold what I would eventually do with my life. But so I worked on an ambulance, and I actually also worked a lot in other things and other settings throughout undergraduate. I don't know that I always wanted to be a doctor. I actually wanted to be an astronaut when I was much younger, but at that time, oh, women didn't become astronauts. I decided that there was a lot of problems here down on Earth, and I should pay attention to them. And I was drawn to medicine and to getting my MD, which actually turned out to be one of the best decisions I ever made in my life. I actually love practicing medicine and loved the work that I did. I think that medicine per se, medicine, MD, is a calling. I think there's a lot of other stuff that people can do within health. One of the groups that I've worked with, actually through NC State, going on alternative service breaks, was Timmy Global Health. And one of their sayings is, not everyone can be a doctor, but everyone can be a healer. And I really hold that very true for two reasons. First of all, not all doctors heal. So it's really important to be able to heal people, whether you're a doctor or anything in either healthcare or just life in general. But it also means that, there's a lot of space for people to go into a health career without going to medical school, nursing school, PA school, pharmacy school, any of those things. If that's not what's calling you, God, they're too hard. Don't do them. There's lots of other alternatives. And I think it's really important for people to understand that. Another saying that I love, and I say this a lot to students who I mentor, when my son was coming to NC State during orientation, it was said that we're training your students for jobs that don't exist. And I think that that's really important for people, again, students, to understand that, know where your heart is and see how to create a career that answers where your heart is, and go that route. So I think that those are some of the important things. I could go on for days. Why did I start doing public health? Well, I got into public health kind of backwards. Although I guess it's another thing that was always kind of there. So I went to medical school on a public health scholarship, not ever thinking I would ever do public health. So when I finished medical school and finished my residency, I actually owed 3 years back in time. There were 3 ways to pay that back. I could either go into the public health service, and that wasn't something I thought I'd be interested in. I could sign a contract and work in an underserved area, or I could go and work in something like the Indian Health Service Corps, Indian Health Service or prison service. But I had to do all of those for 3 years, and I just didn't think I wanted to do that. So I wound up doing what was called the private practice option. And at that time, you had to work in an area of physician shortage, and they did not count at that time physicians who were assigned to hospitals in that formula. A good friend of mine, and there's a common theme in my life, good friends were always good at telling me what I should do rather than what I thought I wanted to do, and they were almost always right. So listen to your good friends. A good friend of mine worked in the emergency department part-time at what was then Baltimore City Hospital, and said, hey, they're hiring physicians. And you know, Julie, this is you. You'll never go do internal medicine. That's not your personality, and you won't be happy. And you're either going to do critical care or emergency medicine, and I couldn't do critical care because of my scholarship payback. So I went and looked at the emergency department, and indeed they were hiring people. So I wound up taking a job in what was then Baltimore City Hospital, and started in emergency medicine there. It was a Hopkins affiliate. It still is. It's a different name totally now. It's called Bayview. So I got involved with the Hopkins emergency medicine program. Loved emergency medicine, and wound up getting boarded in both internal medicine and emergency medicine. So I went down that path. Again, you don't hear public health anywhere in there, other than, you know, thank you, they paid for my school. So kept doing that for a number of years. Actually moved from Baltimore City Hospital to, as we used to say, under the dome at the big house, to the main Hopkins Hospital in emergency medicine. Again, loved every minute of it, but after 13 years of practicing in an inner city, high trauma, high HIV rate, 99% plus HIV rate in the 80s and 90s, I decided that I was burnt out, and can tell you the moment that I became burnt out. And you might say, well, that kind of harkens back to your public health soul. In the meantime, I had gone and gotten my MPH at Hopkins because I wanted to take management courses. And honestly, the reason I got an MPH and not an MPA was because I could walk across the street and get my MPH, and I had to travel 5 miles to go get my MPA. So it was easier to walk across the street. But I got the bug for public health. And what I like most about public health is that it appeals to my love of discussing ethics and the implications of history on medicine and health and social determinants, for those of you who have been in my class. So I just really love that, and it really appealed to that part of me. So I kept muddling along and finally left emergency medicine because I got involved in disaster work. I had always been involved in disaster work, but I got more involved in it, and wound up teaching bioterrorism in the 1990s all across the country. And got engaged with people at USAMRIID and Frederick, and working on bioterrorism issues. In 1999, 2000, the Centers for Disease Control funded a bioterrorism position in every state's health department. A friend of mine, there it is again, saw the job description, showed it to me, and said, oh my God, Julie, this job is for you. And I applied for it and got it. So I left the practice of direct patient care and went to the practice of bureaucracy and working in a public health department. Wow, very different. But this was 2000 and nobody really knew what to do with bioterrorism. That was the whole point. And so while I'm trying to convince people that we did need to worry about it, lo and behold, 2001, September 11th happened. And then shortly after that, on October 19th, Amerithrax happened. And I was the bioterrorism coordinator. In fact, I was the entire bioterrorism program for the state of Maryland. Grabbed a couple of people, and suddenly we're practicing public health emergency preparedness. And that's what the craft developed into. So, now all of a sudden I am practicing public health because I'm collaborating with everybody at every level. I have to pay attention to health disparities and access disparities. Who do we treat? Who do we take care of? Who don't we treat? How do we make big policy decisions for the population as opposed to the single person? So I did that more and more, and finally in 2006 decided I didn't want to be in the National Capital Region anymore after responding to anthrax, smallpox vaccination campaign, SARS, tularemia on the mall, you name it, we were doing it, and said, nope, I'm done. The same job opened up here in North Carolina. I came down to North Carolina, and during my interview, I said, okay, so what's your biggest threat? And they said, hurricanes. And I said, okay, I don't know much about that. How about number 2? Hurricanes. 3, hurricanes. And when I got down to 10 and somebody said, oh, wind and flood from hurricanes, I said, okay, well, it's a different thing, but I'm game. And I came down to North Carolina, where I did that from 2006 to 4 years ago. I had been teaching here at NC State. I had been teaching global health because of my affiliations with the One Health program here and at the vet school and across the triangle. And some of the students said, you've got to come to Ecuador with me. And I went on my first service break in 2014, and oh wow, loved it again. And when the position at Student Health opened up to be able to do patient care, do some management, and teach, I decided this is the place for me. So I've been here ever since, and divested myself of public health emergency preparedness and say, good, I don't have to respond to any more disasters, until COVID came along. And suddenly I'm like, oh my gosh, can I never get away? So I've been doing that. So that's how I got involved in public health. It's probably been there all along, but it certainly wasn't my immediate career path. So what does a day as a public health professional look like? So the difference between public health and medicine is that you're practicing on a population and not on a person. You're using the same philosophy, you're using the same framework. You create a list of, if there's an outbreak, you look at the symptoms, you create a list of differential diagnosis, just like you would in medicine, except, you think about what would affect the population. You look at interventions. In public health, we call them interventions. In medicine, you call them treatments. You look at testing, it's the same in both. And then you implement policy in public health. A typical day might seem a little boring because most public health practitioners practice in government. And so you have to put up with the bureaucracy of government, which means you're going to a lot of meetings and talking a lot. You're trying to develop policy, and policy is never easy. If it's easy, you're not doing it right. You have to talk to a lot of people. You have to get points of views. You have to get feasibility. You look at science, you look at that practice. If you're working in public health that's looking at disease outbreaks, you can be very scientific because you collect data and information. You analyze it. Maybe you do a case controlled study to make sure that your hypothesis is correct. And then you launch an intervention to try to prevent other illness and disease. It's a lot of prevention, and it's a fair amount of intellectual work. I think a big difference between public health and medicine, at least I felt this, was that I had a lot more buddies in public health. I could go down the hall and talk to the other epidemiologists and say, hey, I think we should do this. What do you think? And you sit and you can kind of collaborate. It's much slower in public health. The hardest thing for me to learn was, Julie, take a breath. It's not going to happen in 10 seconds like it does in the emergency department. So it's different that way. So it can be much more cerebral than the practice of medicine, and it's a different pace. And again, you're dealing with a population. So that's kind of like a typical day. I will also tell you that there is no typical day. In the emergency department, I knew I was going to be seeing patients all day. I may not have known what those patients would have when they walked in, but I knew I was going to see a lot of patients, and I knew I was going to see a lot of them. And I'm sure that, and it's true here in student health, and it's true everywhere. You have your schedule. Again, what people complain of is hardly ever what they really have, and so you're always balancing it. In public health, you can walk in and think you're going to get 10 things done, and at the end of the day, you've done one, and it has nowhere near the list that you started with. So it's always an exciting challenge to do that. I think that was kind of part of what I felt in public health. We also don't see the immediate return like you would in healthcare, but they're there, and you know that you're really impacting society. When I look at some of the things that my colleagues in public health have done, I'm jealous. Even though I've done a lot here on campus, and for all intents and purposes ran a local health department with 40,000 students plus. So yeah, it was basically public health in practice. Do you need a master's, or can you just major in public health and find a career out of college? That's a hard question. It kind of depends on what you want to do with it. You can probably do you can do some good shoe leather public health without a master's. You know, you could go and work for a public health agency, maybe a local health department, probably not a state or higher federal level health department. Without a, you need a master's for the higher levels, state and federal. But you don't need one. And you can go work for a non-governmental organization, very reputable, very detailed ones. I think most people who have a career in public health wind up getting a degree. Doesn't mean they get it right out of school. And if any of you have ever talked to me, you know I'm a big advocate of saying, why don't you take a year off and go find out what you really want to do in public health? Because public health is a very broad topic. It's like saying, I'm going to be a doctor, right? What kind of doctor are you going to be? You kind of have to figure it out. And so when people say to me, I want to get an MPH, I'm like, well, what kind of MPH do you want? And if they look at me wide-eyed, I say, go take a year and go explore what you want to do. So I think that that's actually a really good thing. And that's really common in public health, to just take a couple of years, go work, get some experience under your belt, and then decide what degree you even want. Do you need an advanced degree above? So first of all, there's different masters. There's a master's in public health, which is really a master of the practice. So it's a survey masters. You take a lot of different courses. The foundation is epidemiology and biostatistics, but then you branch out from there and you take a lot of different ones. You can focus, you can track it, but by and large, you're taking a lot of different courses. There's a master's in health science and an MSc, not as common, but a master's in health science is a true master's degree with a thesis. And usually a research project. So it's different than an MPH. And MHS is more like a master's in biology or something like that. You're really learning more about a scientific application, if you will, or scientific discipline. So you might get an MHS in statistics or an MHS in epidemiology. And then there are two types of doctorates. A PhD is focused on doing research. So a PhD in public health, you're really staking your claim that you're going to do probably academic research or good clinical trials, something like that. There's also a DRPH, which is a doctor of the profession of public health. So people who have been in public health for a number of years have their MPH. A colleague of mine who's actually a health director in Florida right now, local health director in Florida, is just applying for a DRPH. So that's a bit more of a doctor of the practice, and you learn a lot more about policy, and you hone your skills in epidemiology and statistics and study design and those things. What other questions? How has COVID affected your job? Oh God, I have no idea. I really have expanded my job to at least 3 full-time jobs with COVID. So, with my experience and my background, you're bound to be fate. We call it fate, call it God, call it whatever you want, but I call it fate. Fate kind of puts you in places where you need to be. And the luck of the draw is that even though I kind of walked away from public health preparedness, it's skills you never lose. And so when COVID came, I wound up being called up. And so I've been, everything from talking to students that they're COVID positive and what are we going to do now, to, advising the chancellor and the provost on what policies to make. So I've done the full gamut here. We have 3 physicians now in student health, including me, 4 if you include Dr. Bo Passfield up in gynecology. But so there's 4 physicians here, and being the only one with public health background here on campus just puts a lot of responsibility on me. So it's been crazy. So again, I've done the full gamut, and when I've done a lot of the tactical work, as I call it, the day-to-day, sending notices out, sorry, you're in quarantine or isolation right now, that's very time consuming. So it's been affecting, and I've had to dismiss some of my responsibility in student health, running student health. So there's things we haven't done, because when there's a pandemic, you're not going to do everything. Like, we haven't done travel clinic. We haven't had to, but we haven't done it in a year and a half. We're starting up again, but we haven't done it. So walked away from some of those things. And then I teach, which I've been able to do, and to the great patience of my class. At times I walk in the class and go, so what are we talking about today? Not COVID. So it's been like that. So it's been a whirlwind, as much for me as it has been for you. So hats off to all of you for surviving it as well. I feel like I'm a survivor. What do you see myself doing going forward? Wow. I don't know. You know, I'm getting older. I really, one of the big things I did to come here was I want to teach. And I'm, for those of you who know me, I'm dedicated to global health and building the global health program here at NC State. I think NC State has a lot of unique characteristics and opportunities and research and classes, than our colleagues down the road, 2 colleagues down the road who have very strong global health programs, but both of them are health medical model types. We're not. And I think that's a real benefit for student health, for NC State. And so I've been working on that since 2014. We have the minor. For those of you who don't know, we have 87 students in the minor. It makes that one of the largest minors at NC State. We're hoping to move it more and build it bigger. So we'll see. That's where I want to go. That's where I want to go next. Oh, another question. Would you recommend taking abroad opportunity studies? Absolutely. Why? A couple of reasons. First of all, it's hard, even though global health is local health, you need to understand multicultural issues. And while we have multiple cultures here in the United States, I think it is best learned by immersing ourselves in totally different cultures, and seeing how people are the same and seeing how people are different. There's also a cultural competency that you learn from that, how to be tolerant, how to understand, how to be inquisitive, and frequently how to be a minority in a crowd, which maybe some of you unfortunately have experience on a negative side of that, but maybe not. And so I think people do need to travel. The world is a very small place these days. And so I think you need to take that opportunity. Does it have to be health related? No, it does not. If you keep your eyes and ears open and watch, I think you'll see a lot, and you'll be able to bring that back home. Of course, it helps to do something health related in another country, and understanding that. I think it's too easy for Americans to be almost colonial in their vision of what global health looks like if they haven't had that experience and seen it, really at ground level. It's even though we say we have poverty in the United States, when you see abject poverty where people are making less than $1 a year, it's a whole different game. So very, very important. Yes, I highly recommend it. And also it's fun. And second of all, it's just good. It's just healthy. What else? So there's a sub question about COVID, about what kind of, do I think that that'll place a demand on public health? Public health in this country right now is in tatters. Public health is a practice. They're exhausted. They're just exhausted, and they are very beat up. I've talked to a lot of friends who are practicing pure public health, and they tell me, you just feel like you can't make the right decision. Everybody knows that public health is, this balance between science and politics and policy, right? Everybody in public health knows that. And, when you're in public health, you frequently come out of a meeting and go, well, I guess we're not doing that today, even though in your heart of hearts, that's the right thing to do. But you tolerate it because you know that you can do a workaround and that there's time to develop a workaround, or, sooner or later people will kind of wake up, and do what really needs to be done. I think with COVID, it's been very polarizing. It's been very emotional. it's, it's another disaster on top of another. We just got out of Ebola, we just got out of this, we just got out of that, and now boom, there's COVID again. And it's gone on for 20 months. So people are really tired, emotionally, physically. These are practitioners in public health. So they're a bit in tatters. That's number one. The other thing about public health is that, public health in the United States is pretty unique than it is in other parts of the world, in that it is a totally separate discipline from medicine. You go to other parts of the world and people practice, doctors practice public health all the time, like real public health all the time. And that's not what we do here in the United States. And, a couple of years ago, I was talking to a group of students, and one of the big questions I got asked several times was, when did you stop being a doctor and go into public health? And I was like, I've never really stopped. So that notion that I left medicine and went into public health, I never left medicine, right? I used the same framework that I described earlier that I did with a patient and I did with a population. So it's the same thing. So we have this very fractured idea about the difference between public health and medicine in the United States. And I think that if COVID has proven anything to health, it's proven that it shouldn't be two different things, that the physician advising you about a COVID vaccine is practicing public health. So hopefully that's one of the things that will come out of all this. I know that it has for a lot of specialists. A lot of specialists talk to me now and say, boy, I appreciate public health more now than I ever did, and understand how hard your job is. Another question I got was, are there other countries that you admire in regards to public health? Oh, wow, yeah. And different aspects of public health. Typically where there is a universal healthcare system, it is integrated in their public health system. Their public health system is integrated in that universal healthcare system. So you see a lot of cross connections. England is the biggest example of a uniform health system, universal health system. Australia has an incredible public health system that's working really hard on eliminating disparities and building resiliency. Those are the big ones. There's also some low-income countries that, they don't have like the biggest and the best public health laboratories, but they're doing incredible work with vaccination campaigns and trying to get universal vaccines out there. So there's a lot of places in the world that are doing bits and pieces of public health that are really important. And I think that that's why studying global health is so vitally necessary, because you learn that there's no one size doesn't fit all. What works in one place isn't necessarily going to work in another place, but you know what? It's still a shoe, and it's still, it's still something, and you can learn from the successes and say, well, how did they vaccinate so high? And, did they use community workers, or, they appeal to, religious leaders, and that's how they did it. Oh, wow, we can use that someplace else. So to me, that's what's so cool about it, is being able to learn from other people's successes and other people's failures and see where it didn't work. And unfortunately, we're usually, likely to repeat those failures, but we try not to. Okay, there's a question here. Do you think that global health with primarily focus on non-communicable diseases moving forward? Oh, granted another pandemic doesn't happen. Yeah, that's the problem, right? We keep getting reminded, hey, don't forget communicable diseases. Well, we focus on non-communicable diseases. Well, again, I can't see the whole Gamilla of you, but if you've taken my class, you know that even in low-income countries, which traditionally had to worry about infectious diseases and communicable diseases, they're stuck with the dual burden for now. They're working on non-communicable diseases, and guess what? Non-communicable diseases like diabetes and heart disease make you very susceptible to communicable diseases. So I think that. Do I think that we'll shift away from communicable diseases? No, I think that we will have to deal with both, which is hard. If you only have, $1 whatever, $1, $1,000, or $1 million, if you only have a small pot to pull from, you're going to have to split that pot between communicable diseases and non-communicable diseases. And non-communicable diseases are hard. How did we fight COVID? We wore masks, we stayed away from each other, we got vaccinated, right? And that's how we tested a lot, right? That's how we got that's how we got through it. And then so to change your behavior with a non-communicable disease, because unfortunately, many non-communicable diseases have a lot to do with behavior. It takes a long time to change your behavior, to get you into a new habit. It took us, 40 years to decrease cigarette smoking in this country, at least. So it takes a long time, and it's multi-generational. So non-communicable diseases is very difficult to fight, but we have to do both. We can't do just one. And we're also learning this year and last year that when there is a huge communicable disease issue, deaths from non-communicable diseases rise a lot. So there's been a lot of extra deaths from COVID, extra deaths due to non-communicable diseases in the face of a COVID pandemic, because people don't go to the hospital, they don't get screened, they don't get treatment, because everything gets shut down while you're dealing with a communicable disease. So it distracts resources. Yeah, not easy. It's challenging. It's one of the grand challenges of global health, but we can do it. It's just going to take time. If I had stuck with the MD route, where do you think you would, I'd probably be retired, honestly. I think that it depends what your personality is like, and I think it depends what your tolerance is like. So let me try to explain that. I practiced emergency medicine for 13 years, at least, in a very high volume, high intense emergency department. I outlived the natural course of emergency medicine at the time, because the burnout rate was anywhere from 5 to 7 years. So I lasted even longer than that. A good friend of mine, his idea was that you, as a physician, you are destined to see X number of patients within your lifetime. He didn't know what that number was, but a number of patients in your lifetime. So if you saw a lot of them very fast, you weren't going to live very long in the healthcare industry, right? And so that's what we saw, emergency physicians shifting to other practices. A lot of the practices changed, so that demand is not there as much. And I think some of the changes in the training programs help with that as well. But I think that I do believe that if you see a lot of patients intensely, very quickly, you're not going to practice very long. And unfortunately, as I was progressing through that career, that was the case. We worked 12-hour shifts, and heavy 12-hour shifts. And when I was training, we worked every other night and every third night on call. So, you saw a lot of patients right away. There's been a lot of change in training, and there's been a lot of change in the practice, so that those demands aren't there. And those demands are both emotional and physical. And so, my knees hurt, and they hurt because I was on my feet 12 out running around 12 hours a day for the better part of my life. So I think that wear and tear on your body is less now. So that's a lot of encouragement for you. And I think that emotionally, there's things that I've learned how to do to compensate for the emotional traumas that I lived through. But a lot of that emotional support wasn't there either. So 1 out of 10 of my colleagues are either substance abusers or alcoholics, and those are the statistics. 1 out of 25 have significant major depression, including suicide. Successful suicide. So some of that isn't there as much anymore, and I think that that's really a benefit. So it's hard for me to answer because I've been in the practice now for 40 years, but it's very different for you coming out. I think that we've done a lot about the practice of medicine to make some of that easier and less traumatic, because training a doctor these days is a huge investment. It's a huge investment for you as training. It's also a huge investment of the program that gets you through that. And so that's just doctoring. There's also huge investments in any other health profession you go into. And I think it's all the same, just on scales. Does that make sense? I hope that makes sense. What other specialties interested you? Oh, I was always critical care, emergency medicine. Oh, I knew that right from the beginning. Yeah, that's just my personality. I mean, I had a very good colleague who I worked in the emergency department with. He moonlighted in the emergency department, and he was a dyed-in-the-wool primary care physician. He loved seeing little old ladies with high blood pressure and diabetes, and they loved him. We would frequently change shifts with each other. And one day I'm standing in the emergency department with him, and the radio to the paramedics is going off and all the alarms are beeping and there's all this noise and patients are screaming, just the typical picture you can imagine. And he looks at me and he goes, "Oh my God, how do you do this?" And I looked at him and I said, "Mel, how do you do what you do? Because that would drive me crazy seeing these little old ladies day after day. I mean, they're sweet, but oh my God, they're never going to get better." And he said, "No, they will." And I'm like, "Oh." And so it's just one man's ceiling's another man's floor. And I think it's great. That's what makes the world go round. That's why I could do emergency medicine and, get excited about it. And he could do primary care and get excited about it. Like, that's what I loved, sending patients to see him because I knew that they'd be well taken care of. So you got to find what you like, because otherwise you're going to, again, it's too hard. Don't do something you don't like, please. Way too hard. All right. What would you tell a student looking into public health? On the other hand, what would you want a student to go to the MD route to know? Yeah, okay, good. So if any of you have ever talked to me, first thing I ask you is, so why do you want to be a doctor? If they tell me they want to be a doctor, or why do you want to do public health? And I listen to what they say. And if they say, I get really excited about, taking that patient through something, and gosh, getting that patient well, that's my dream, to have somebody look at me and go, "Thanks, doc." That person needs to be a doctor. If I have somebody who says to me, I want to make a difference in the world, I want to make a difference in the world. I want to work. I'm from a county that doesn't have good public health, and I just want to be able to, work on sexually transmitted diseases and just, get people through HIV or something like that. I said, "Oh, you need to go into public health." And so I think that's kind of, to me, those are like the polar ends of the spectrum. So I tell people, look, if that's in your heart, if you light up when you talk to me about your clinical rotation, you just sit there and go, "God, I got to see surgery yesterday. It was the coolest thing ever." I'm like, "Oh God, you need to go to medical school." If they say, "Oh, I saw surgery yesterday, I'm not so sure this is, I said I wanted to do health and my parents told me you should be a doctor, but I'm not really sure I want to go through that." I'm like, "Okay, let's talk." And I think that's, I'm not making light of that. That is a critical cut. That's a critical piece of it. Again, not everybody can be a doctor, okay? And not everybody should be a doctor. Dear God, no. All right. Everybody can be a healer on a different scale. And I think that, every profession where you apply your knowledge, your skill, and your personality to the dream and the passion you have is the right choice for a career, period. Okay, regardless of what anybody tries to tell you. And I think that we get caught up in perceptions and TV show right personalities and say, "Oh yeah, I want to be House." Like, really? He's cynical and a drug addict. Do you really want to be like him? That kind of thing. Think about what you want. Think about what you want, what drives you, not what you want to be. Think about what drives you. That's my advice. And it's my advice for public health. That's my advice for medicine. That's my advice for healthcare. That's my advice for engineering. Think about what you like. If you like to tinker with toys and make systems better, that's engineering. Okay. If you like that analysis, I saw a t-shirt that says, "I'm an engineer, I'll fix it." It's okay if it's not broken, I'm still going to fix it. Like that, that's an engineer, right? So I think that that's important to understand what it is that you like to do, and what drives you. At the end of the day, when you go home and put your feet up and you go, I did that today. What is it? And you know what? For some of you who are 19 and 20 years old, you may not know. You may not know. Sure, I knew, okay, gratefully, I knew what I wanted to do, but some of you may sit back and go, oh my God, she just made my life complicated. Yeah, okay, it is complicated and it's hard. So what I tell you is, if you don't know, don't sink into something. Go out and experience something. And you know what? Either take a job that you think is the track you want to be on, or take a job within the career, but maybe something you'll never thought you'd want to do, and try it out for a year and prove to yourself that that's not what you want to do. So, you know, public health is easy because it's easy to find 1 to 2 year jobs and get started. Healthcare is a little different, regardless of what healthcare you're going to do. It's a little bit harder to find the 1 to 2 year jobs and cut your teeth and say, is this really what I want to do the rest of my life? But there's no harm and no foul in it anymore. In my day, there was tremendous stigma on people who took a gap. And I saw friends in medical school who crumbled because of that, who thought they wanted to go to medical school, did it, and were like, oh my God, this is like the worst possible thing. I want to be an artist, but everybody convinced me I wanted to do this. And so they were miserable, and it's just too hard. It's too hard to get in, it's too expensive, and it's too hard to stay in. And you're going to be depressed and miserable and hate it. Who wants to do that? Hope that makes sense. I can't see any of your faces, so I don't know anymore. Nope, I can't. So I don't know how this is resonating, or it's not. So feel free.
I think that was a good little way to start wrapping up. If anyone else has any more questions.
Wow.
Dr. Casani, can you see
I can
me
see
at
you.
least? Okay.
Yeah, I can see you. Yeah, wow, I can't believe that was 45 minutes.
No, it was really good. I really enjoyed the in-depth things. I enjoyed hearing more about state too and how it's affected, our campus and our community. Does anyone else have any more questions specifically? And thank you to everyone who sent me questions in the chat. That was helpful. If there aren't any more, I think we can start wrapping up. Thank you, Dr. Casani, for coming to talk to us. I think it was really informative. I learned a lot about what it means to be a public health professional and why you chose to do it along with your medical career. So thank you so much for coming to talk to us.
More than welcome. And any of you, I say this and then I get a lot of appointments, but seriously, if any of you are just sort of, just want a little bit of guidance or struggling with it and want to chat, I'm more than open to do that. Give me a little bit to give me another week to get through COVID, but seriously, if you want to chat, I'm more than happy to do that, because just walking through that with people and just getting either your ideas validated or your questions answered is so critically important. And it's a real struggle these days. So please take advantage of that. And there's a couple of other people here on campus now that I think will help as well.
Yes, for sure. Definitely. Okay. Thank you so much, Dr. Casani. I'm just going to go ahead and share our attendance slide at the end. Can you guys see that? Okay, I think it's up. This is our last meeting, so if anyone else has any other questions, just let me know. And I put the attendance slide up there, scan code up there, sorry. I hope you guys have enjoyed the semester. If you have any other questions, concerns for next semester, let me know, and be on the lookout for our recap of this meeting, because I'll be sending out stuff about next meetings for next semester and how that will work out. So just let me know if you have any other questions. So stay safe, good luck with finals, and enjoy your winter breaks too.